Hi guys, welcome to Stress Free Tuitions. My name is Venon Sofa, and in today's video, we are going to look at these questions that are coming from Lobby's and Contran Review of Pathology, 4th edition. Why are we looking at these questions? These questions, they are the same questions that came in Pathology Test 1 that was written in 2022. So it's very important for you to go through these questions because it's going to help you prepare for your upcoming test. So if you want, you can go and check out the paper. It is in the group, Pathology Test 1, that was written in 2022. We posted it in the Telegram group. You can go and check it out. Without wasting time, let us get started. The first question that we have is, a 77-year-old woman has chronic renal failure. Her serum urea nitrogen is 40 mg per dl. She is given a diuretic medication and loses 2 kg, which is 4.4 pounds. She reduces the protein in her diet, and her serum urea nitrogen decreases to 30 mg per dl. Which of the following terms best describe cellular responses to disease and treatment in this woman? First of all, we need to understand what urea is. So urea, it is simply a protein metabolite. What we mean when we say a protein metabolite, we mean it is a product of protein metabolism. So when you break down the proteins, you end up producing urea. And what you should remember is that urea is very toxic to the cells. So it damages the cells, especially the cells of the kidneys. So this urea, it must be excreted from the body as quickly as possible. Okay? So in this patient, you can see that there is too much urea in the blood or in the serum. But what is a normal level of urea? So it differs based on sexes. So for males, it's different as well as for females. Okay, so if you look at the normal blood level of urea in the blood for males. Okay, so the normal blood urea level for males, it is actually in a range, as well as for females, it's in a range. So what is the range? So for males, it is from 7 to 24 mg per dl. That is the range of normal urea level in males. Okay, and then for females, it is also a range, but it's a bit lower. For females, it is 60 to 21 mg per dl. That's for females. That is the normal range of urea in the blood. But if you look at this patient, this female patient, she had the 40 mg per dl. That was too much. Okay, that's the amount of urea in her blood. But we can see there that the cause of this is because of chronic renal failure. But the other cause that can lead to a lot of urea in the blood is actually high intake of what? Of proteins. If you're taking too much proteins, those proteins eventually will be broken down to form urea. So if you're producing more urea in your body than you're excreting, you're going to have elevated level of urea in your blood. Okay? And even if both of them can happen at the same time, where a patient or a person has got renal problems or renal failure, and then this person is taking a lot of proteins, what will happen? You're producing more urea than you're excreting, because your kidneys, they're incapable of excreting urea. Okay, so in this patient, the cause of that we've seen it is because she had chronic renal failure, which means the kidneys were not functioning properly. Okay, but she was given the drugs. I mean, the drug, which is a diuretic medication. What do these guys do? The diuretic medication, these are simple drugs that when they are given to a patient, they will increase water excretion. Okay, so the way they do this is actually by increasing the excretion of sodium. So they are going to act in the kidneys and increase the kidney excretion of sodium. And we know that sodium, it is an osmotically active particle. When we say osmotically active particle, we simply mean that sodium, wherever it goes with water. It attracts water. So when you're excreting a lot of sodium, you excrete water together with urea. Okay, because urea is one that forms urine. Okay, so you're excreting water through urine and sodium through urine together with what? With urea. So you're going to reduce the urea level in the blood. Okay, the other thing that you can do, that this patient also did, is reducing the protein in her diet. Okay, that will also reduce the amount of urea being produced in the body. But here, the question that we have is, which of the following terms best describe cellular responses to disease and treatment in this woman? Okay, so what is happening here is that when urea level increases, the cells in the blood, as well as in the kidneys, they are going to be exposed to this kind of an insult. Because remember what we said? We said urea, it is toxic. So it's going to cause pressure on these cells, okay? So the environment is going to be adverse, okay? So what will happen is that these cells now in the blood, as well as in the kidneys, they are going to undergo certain changes in order to suit the new environment. Okay, so if there is any injury to the cell, or if there is any insult to the cell, or pressure applied, cells, they undergo certain changes in order to accommodate the pressure. Okay, that's what happens. So that changes that cells undergoes through are what we call adaptations. So a cell is going to undergo adaptation in order to suit the new environment. So the same thing happened in this patient. Cells were exposed to this insult, which is urea. So they had to undergo certain changes until urea level came back to normal. Okay, so that's what we call adaptation. So that's the best term that's describing what was happening in that patient. So the answer there is A. Okay, I'm not going to waste talking about apoptosis because we know this is simply programmed cell death. Okay, and then necroptosis, we are simply talking about this is actually a combination of necrosis and the apoptosis. Okay, but what you should know is that this one, it is also programmed but doesn't use the caspase 8 enzyme. The caspase 8 enzyme is the enzyme that causes apoptosis, but it is not there in necroptosis. Okay, so this one, it's actually the one that is involved in cells that have been hijacked by viruses. So those cells that have been hijacked by viruses, these viruses, they release an enzyme or a protein that inhibits apoptosis. So these viruses, they release proteins that are going to inhibit the caspase 8 so that it prevents apoptosis of this human cell. Because viruses, what they do is that they use the machinery of the human cell. So if the human cell dies, the virus dies. So what these viruses do is that they go and prevent the apoptosis of the cells they are invading. Okay, an example of viruses that we can give is cytomegalovirus. Cytomegalovirus, it is a virus that does the same thing I'm talking about here. So now, this cell that has been hijacked by what? By the virus. It's going to fail to undergo apoptosis, which is programmed cell death. It's going to fail to die. What happens? Well, there is a process that we call, another pathway that is used by these cells now, these human cells. Okay, they use the TNF alpha, tumor necrosis factor alpha pathway. Okay, and they are going to initiate certain processes that are going to occur, and then at the end of the day we are going to form pores in the cell membrane, and those pores, they are going to allow the extrusion of what cytoplasmic contents such as proteins and other macromolecules from cytoplasm going to the outside. And once those chemicals go to the outside, they are going to initiate immune response. The immune system is going to know, okay, something is wrong with that cell, and it's going to come back and digest the cell. Okay, so which means when the cell is digested, even the virus that has hijacked that cell will also die. That's what we call necroptosis. So necroptosis, it is an alternative when apoptosis fails and necrosis is not there. So the alternative is necroptosis. Anyway, I won't stress much on this because it's not our focus, but if you've got a question on that or you want to learn more about that, you can actually just text me on WhatsApp, then we'll have a one-on-one talk. Irreversible injury, I'm not going to waste time on that. That is self-explanatory. Metabolic derangement, this is simply talking about defects in the metabolic pathways. Okay, for example, the production of ATP. Yeah, so those things are associated with irreversible cell injuries. Okay, so the answer there is adaptation. We go to question 2. A 53. Okay, so question 2. A 53-year-old woman with no prior illness has a routine checkup by a physician. One examination, she has a blood pressure of 150 95 millimeters of mercury. If a hypertension remains untreated for years, which of the following cellular alterations would most likely be seen in a myocardium? First of all, we need to understand something about blood pressure. What is the normal blood pressure? So the normal blood pressure is 120/80. Okay, 120/80. So that is the normal blood pressure. Now, what does these numbers mean? What does 120 mean and 80 mean? So 120, the numerator, this number, it is simply telling us the systolic pressure. And then the 80 is telling us the diastolic pressure. Now, what the heck is this? What is the systolic and diastolic pressure? All right, that's a good question. The systolic pressure, we're talking about the pressure in the arteries. What are these arteries? We can talk about the aorta and all the arteries in the body, rather, being short, okay? The aorta and the pulmonary trunk and the other arteries, the branches. Okay, so we're talking about those arteries. So when we talk about systolic pressure, we're talking about the pressure or the blood pressure in the arteries when the heart contracts. Because the heart, it contracts. When it contracts, it pushes the blood into the arteries. So when it contracts, it pushes the blood into the arteries. So the blood pressure in the arteries, it is very high when the heart contracts. Okay? But again, after that, the heart relaxes. When it relaxes, the blood pressure in the arteries drops. Okay? And that's what we call diastolic pressure. So systolic pressure, it's blood pressure in the arteries when the heart contracts, and normally it is 120. And then diastolic pressure is the pressure of blood in the arteries when the heart relaxes. And that is normally 8 millimeters of mercury. But if you look at this patient, she had 150 systolic pressure and 95 diastolic pressure. That's too much. Okay? So it simply means that the heart of this person, it is pumping a lot of blood. But how does the heart pumps a lot of blood? It pumps a lot of blood by increasing the heart rate. So your heart starts pumping blood at a fast rate. Okay, the heartbeats are going to increase so that it pumps more blood. Okay, what else happens? The other thing that can happen is that the blood vessels, when they constrict, when they become smaller, the blood pressure increases. Okay, so this person was pumping more blood, or the blood vessels were small, they are constricted. And what happens is this has got effect on the heart, because what you should know is that the heart is made up of this type of muscle that we call cardiac muscles. Okay, there are three types of muscles. We've got the smooth muscle, the cardiac muscle, and the skeletal muscle. So the cardiac muscle is the one that makes up the heart. So the cardiac muscles is what we call the myocardium. And what you should know is that based on proliferation, I've got three types of cells. So we can look at this. Based on proliferation, I've got three types of cells. We have got the labile cells, and these cells are contagiously dividing cells and renew themselves. For example, the skin epithelium, mucosal lining of the GIT, hematopoietic cells, which makes blood cells. So the labile cells, these are cells that keeps on dividing, replacing the old ones. That's what they do. They have given examples there. We also have cells that we call the quiescent cells, also known as stable cells. So these cells, they only divide when there is a need. For example, cells of the liver, the hepatic cells or hepatocytes. Also cells of the kidneys and cells of the pancreas. Then we also have cells that we call the permanent cells. The permanent cells, these cells, they do not divide. Okay? No matter what, they do not divide. They are non-dividing cells, so when they are injured, they are healed by forming a fibrous tissue. Example of this, we have got the nerve cells, skeletal cells, and the cardiac muscle cells. Okay? That's what you should remember. So the cardiac muscle cell also, they do not divide. Okay? And skeletal muscle, they also do not divide. That's the reason when you injure yourself, let's say you've got a trauma to your skeletal muscle cells, when it heals, just forms a scar, which is a fibrous tissue. Because those cells, they cannot be repressed. But what happens is that when your skin, let's say the top layer of the skin is damaged, the skin will replace. If just the top layer, let's say epidermis is damaged to the skin, it can be replaced. Okay? If the epithelial cells of the skin are damaged, that's on the top layer, the most top layer, you find that the epithelial cells will be replaced. But when muscles are damaged, it forms a scar and cannot be replaced. Okay? Because these guys, they do not divide. Same applies to cardiac muscle cells. But now, someone who does now, how do these guys accommodate pressure? How do they adapt? So these guys, the way they adapt by increasing in size. So if you put a lot of pressure on them, they increase in size. You're going to the gym, you're putting a lot of pressure on your muscles, your biceps, they are going to increase in size and they're going to be big. Okay, so we can get back to our question. So we've seen that the myocardium is made up of cardiac cells that do not divide. So these cells, when there's high pressure or high blood pressure, these cells, the way they accommodate that pressure, it is simply by becoming big. Because in hypertensive patient, or when a person has got high blood pressure, the heart is overworking. So there is large workload on the heart. So the heart will start overworking, and when the heart is overworking, it means the cardiac cells are the one which are overworking. So what will happen? for them to accommodate that pressure, they will start producing new organelles. They'll produce new organelles, new proteins, and the cytoplasm is going to become big. As a result, the cell is going to increase in size. Okay? But again, if you look at these options that we have here, they have mentioned other things as well. They have mentioned metaplasia, hyperplasia, hemosiderosis, dysplasia, apoptosis, fat change, and hypertrophy. Now, which one is the answer? So the answer there, it is hypertrophy. Hypertrophy, it is the increase in the size of the cell. Okay, so the answer there is hypertrophy. But now, what are these other things they have mentioned? So let us talk about these other things as well. Apoptosis, we know what it is. Fat change, we know this is a sign of reversible cell injury. What is hemosiderosis? So when a iron is in the blood, it is converted to hemosiderosis. Okay, but where is iron found? So iron, it is found in heme. Where is heme found? Heme is found in hemoglobin. So heme, it's one that forms hemoglobin. When you get heme plus a protein part which is called globin, you form hemoglobin. Okay? So heme, it is actually a porphyrin ring. Okay? And it has got an ion at the center. So it has got ion at the center. And what happens is that when blood cells are being destroyed, let's say if there's a trauma, or let's say if a patient has got anemia, okay? Anemia where red blood cells are being destroyed, what happens is that when a red blood cell is destroyed, or is broken down, or is phagocytized, what will happen is that hemoglobin is broken down. So red blood cells, they are broken down where? They are broken down in the spleen. And we know that the lifespan of red blood cells is actually 120 days. So when they reach 120 days, they are taken to the spleen where they're digested. And when these red blood cells are digested, even the hemoglobin is digested. But this hemoglobin, the globin part, it is recycled to form new red blood cells. But the heme part, okay, I said the heme part, the heme, which is the non-protein part, is going to be broken down in the spleen to form what we call biliverdin and release the iron. So biliverdin is taken to the liver to form bilirubin. So bilirubin is one that is used to form biosalts that are used for lipid emulsification. I hope you read about biosalts. But when it comes to iron, it is stored in the cells in form of hemosiderin. Okay, so if you've got a lot of hemosiderin, it means a lot of red blood cells are being digested. So that can be a sign of what? Of red blood cell destruction, right? It can be a sign of anemia. It can be a sign of a trauma. Okay, so I think I've explained on hemosiderosis what it means. It means high level of hemosiderin. Now let us talk about these other things. So these are other things like metaplasia, hyperplasia, and dysplasia, as well as hypertrophy. These are simply types of cellular adaptations. Let us talk about them. So we can look at this diagram that we have here. So if you look at this, we have got the normal cells here. These are the healthy cells. Okay, so now imagine that there is a stimulus or an insult to these cells. So that insult is going to cause cellular changes in these cells. And once these cells change, they're going to change in a way such that it will help them to survive. Okay, so these cells, they can change either in size or in a number of cells or in the shape of cells. Okay, so they can change in their shape or their size or the number of them. So we can look at the first type of cellular adaptation, which is atrophy. What happens in atrophy? We can see that in atrophy, there is actually reduction in the size of the cell. If you look how many cells we have here, we have got 4 cells, and even here 4 cells. So we can say that in atrophy, there is no increase or reduction in the number of cells, but there is only change in the size of the cell. What type of change? There is reduction in the size of the cell. So you can see these cells, they have shrinked to that size. That's what we call atrophy. What about hypertrophy? Hypertrophy is simply the opposite of atrophy. So atrophy, there is no increase in the number of cells. There is also no decrease in the number of cells, but there is a change in the size, right? Which is specifically decrease in the size of the cell. So hypertrophy is simply the opposite, which means that it is the increase in the size of the cell. So you can see these cells, they're looking bigger than these normal cells, okay? So that is hypertrophy. So it also happens as a result of what? Of certain stimulus or stimuli. We also have another type of cellular adaptation, which is called hyperplasia. So hyperplasia, if you compare these cells to these cells, how many cells do we have here? We have 4 cells, but when we look at this, we have 7 cells. What has happened? These cells, they have multiplied to form 7 cells by mitosis. Okay? The reason they are multiplying is that they want to form a big team so they can work together to what? To resolve that insult. That's what's happening here. So these guys, they are proliferated. But if you look at the size is the same. These cells and these cells are the same in terms of size. So the only thing that is happening here in hyperplasia is that there is increase in the number of cells. Okay, very good point to understand. Now, I want us to look at these two important things that is called metaplasia as well as dysplasia. Okay, so what is metaplasia? So in metaplasia, we can look at those cells, right? Those two guys there at the end, those cells are the normal guys. Even there, you can see those two guys. Those guys are the normal guys. But look at these guys. Look at that heap of cells, okay? And if you look at these cells here, what has happened? These guys, they are columnar cells. They are, they're looking like columns, okay? So like they are columnar cells, and these guys, they're squamous cells, okay? So they are flat, and these guys, they are like cubes. Okay, can you say cuboid or columnar, whatever, but they're looking like, they are different from this, okay? So in metaplasia, there is simply a change from one type of cell to another. So we are changing this type of cell to this. Okay, so in response to a stimuli or an insult, cells can change from one type to another, and that is what we call metaplasia. But when we talk about dysplasia, here we're talking about change from one cell to another, but we're talking about abnormalities that occurs in cell development. So if you look at that cell there, if that cell is affected by certain insult, what will happen? It's going to start producing abnormal cells. Okay, so specifically say like that cell, the gene of that cell is affected, or the gene of that cell is damaged, the DNA is damaged. That cell starts producing abnormal cells. So these abnormal cells can be anything, can be big, can be small. Okay, so you look at these cells here. There are different types of cells. We've got these guys which are very big with a very big nucleus. Those guys are very big, and look at that guy there, very very tiny. Okay, very small cell. So like different types of cells are here. Okay, so it's the same type of cell. Let's say if it's squamous, all these cells are squamous. But the thing that's happening is that these cells, some are flat, some are big. Like they are in the same lineage, but they're just different in shapes. That's what I mean. Okay, metaplasia. If you look at metaplasia, the cells, they're looking normal, but just different lineage. So these are cuboidal columnar cells, and these are all squamous cells. Okay, all squamous epithelial cells. But if you look at these cells here, they are all different. Look at these guys here. These are cuboidal, some are squamous. This is cuboidal, this is squamous. So this one is similar to this one. Okay, so these guys, they are basically like in the same lineage, but just different shapes. That's the difference. Okay, that's what you should understand. And here they have got different shapes. So dysplasia, it is simply abnormalities in cellular development and differentiation. Okay, metaplasia, it is simply the change of a cell from one type to another. Okay, so this happens due to an insult. Okay, now I want us to look at some histological pictures. Okay, so we can actually look at this picture that we have here. So this picture it is showing us the lining of the GIT, specifically the esophagus. So in the esophagus, we've got a type of epithelial cells that are called stratified squamous epithelia. So we've got the stratified squamous epithelial cells that's in the esophagus. So you can see there. Okay, that's how normal the esophagus is. But there is a situation where these cells, they change and become like this. So this is also in the esophagus. Look how the cells are looking. These guys, they are columnar cells. There are even some goblet cells, as we can see. These are goblet cells, but these guys are columnar cells. Look how they're looking. Okay, these are the stratified columnar cells. So the cells have changed from stratified squamous epithelium to stratified columnar epithelium. Cells have changed, and that is metaplasia I was talking about. Now, what leads to this? So the cause of this, there is a condition that we call gastroesophageal reflux disease. Gastroesophageal reflux disease, this is simply a disease where the acidic contents of the stomach, they start backflowing. Okay, they start going back into the esophagus, because normally there is this sphincter. Okay, at the junction between the stomach and the esophagus, there is this sphincter, this muscle that is called lower esophageal sphincter. The lower esophageal sphincter is simply a muscle that is found at the junction between the esophagus and the stomach. So this sphincter, when the stomach is digesting food, this sphincter, it closes. in order to prevent the backflow of acidic stomach contents into the esophagus. So this muscle normally it closes, but sometimes where this muscle becomes very weak and it's failing to close, what happens? What will happen is that the acidic contents of the stomach will start flowing back into the esophagus. The pH in the stomach is very low, okay? It's somewhere below 2. It's very acidic because there hydrochloric acid is produced. So it's very acidic. So imagine these acidic stuffs are going in the esophagus. They cause a lot of damage. In the stomach, there's no damage that is caused because in the stomach, there is actually mucus that is produced, and it actually provides a protection layer to the stomach mucosa. But when it comes to the esophagus mucosa, the esophageal mucosa, there is no mucus that is produced, so there is no any protection. So once these acids or acidic materials that are entering the esophagus, they're going to what? To cause changes in the esophagus, specifically to the epithelial cells of the esophagus. So the epithelial cells of the esophagus, to accommodate that pressure or that insult, the stratified squamous epithelial cells, so the stratified squamous epithelial cells of the esophagus, they are going to change and they become stratified columnar epithelial cells. And this change is what we are calling metaplasia. Okay, so this change is what we're calling metaplasia, and this metaplasia, it has got a special name that we, when it happens in the esophagus, it has got a special name. We call it a Barrett esophagus. Okay, so esophagus which has got metaplasia of this sort, that esophagus is called the Barrett esophagus. Okay, the other area where you can find metaplasia, it is actually in the airway. Okay, in the bronchial as well as in the trachea. So in the trachea, I've got the stratified columnar epithelial cells. So these are ciliated. So the ciliated stratified columnar epithelial cells, they are found where? They are found in the trachea. Okay, so in people who smoke cigarettes, heavy smokers who smoke weed, what happens is that due to that insult, those cells of the trachea, they are going to change. Okay, so they are going to change from the stratified columnar epithelium to stratified squamous epithelium. So they're just going to be help us to change, okay? Because here what's happening is that there's a change from these stratified squamous epithelium to stratified columnar epithelium. But in the trachea, what's going to happen, and in the bronchial, what's going to happen? Just the opposite, okay? Because normally in the bronchial and the trachea, there is this ciliated stratified columnar epithelium, but in people who smoke heavily, what will happen is that these cells, due to that insult, they are going to change. They're going to be metaplastic. They're going to change and become what? Stratified squamous epithelium. And you know these guys, they cannot do anything. Stratified squamous epithelium, they cannot do anything because the ciliated columnar epithelium, stratified columnar epithelium, they have got cilia, and they produce what? They produce, they have got goblet cells that produce actually some mucus, which helps in movement of what? Of stuffs on the hair, okay, which helps in movement of hair and trapping these bacteria and trapping as well as dust. So these ciliated stratified columnar cells, they are differentiated to be specific for their law. So now imagine we have now the stratified squamous epithelium. These guys are not going to do any function. So it's going to be very difficult for this person in terms of breathing, and even they're going to have a lot of conditions. Okay, so I've talked about metaplasia, but when it comes to dysplasia, so this is what we meant. We can see this is the dysplasia. Look at these guys. These are normal cells, but look at the dysplastic cells. These cells have got different shapes, different sizes. So this is dysplasia. Okay, so dysplasia can lead to cancer, but it's not always that it can lead to cancer. So you can look at this diagram here. We've got the normal part of the tissue and the abnormal part of the tissue. So in the abnormal part of the tissue, you can see that the architecture and arrangement of the cells has been changed. Okay, so there is a distortion in the architecture of the tissue. So you look at the tissue here. If you look here, you can see that you have got the basement membrane there. Okay, and we've got cells there. But look at this. The basement membrane cannot be seen. So it means that these cells, they are dividing and they are even damaging the basement membrane, and they're entering into this other layer of cells. Have you seen? So that is dysplasia. And if you look at these cells where they're looking, different sizes, there is no uniformity as compared to here. Even here, there's not much uniformity, but if you look here, these cells, they're looking like there's just nothing there, because these cells are uniform, so uniform. Look there. Okay, there's just some cells that actually are standing out, but many cells, they're looking like one thing. But look at this. Okay, cells just have different direction. It's looking like a porridge of cells. Okay, that is what we are calling dysplasia. Okay, so we'll also even look at cervical cancer. We're going to understand dysplasia well. Let us go back. Okay, so now we are going to question 3. A 22-year-old woman becomes pregnant. A fetal ultrasound examination at 13 weeks gestation shows her uterus measures 7 by 4 by 3 centimeter. At delivery of a term infant, our uterus measures 34 by 18 by 12 centimeter. Which of the following cellular process has contributed most to the increase in our uterine size? Okay, so we can actually look at this diagram that we have here. Let's look at this. Okay, so we have this diagram here of the uterus. So we can see this picture of the uterus here, and we'll see that the uterus, it is actually made up of 3 layers of tissues. So the inner layer is called the endometrium. The middle layer is called myometrium, and the outermost serosa layer is called the perimetrium. But what is this? So the endometrium, it is made up of the simple columnar epithelial cells, as well as the stroma. So now what is the stroma? So the stroma, it is simply made up of blood vessels, the lymphatics, and the connective tissue. So what you are going to find in the endometrium layer is that you're going to find the blood vessels, the lymphatics, the connective tissue, as well as the simple columnar epithelial cells. And that is a very thin layer, as you can see. So that is the layer where the what? Where the embryo implants. Okay. Then we also have this big layer, which is the myometrium. This is a very important layer when it comes to cellular adaptation during pregnancy. This is very important because you can see it's very thick. And myo means muscle. So myo means muscle. So this one is made up of muscle. What type of muscle? Smooth muscle. So there's smooth muscle in that layer. And then we have got a small layer outside, which is called perimetrium. So perimetrium, it's actually made up of epithelial tissue, okay? It's actually made up of epithelial cells, specifically the squamous epithelial cells. So that one, it is sometimes called the serosa. Okay, that's the serosa of the uterus. Okay, so we've talked about that. Now, let us go back to our question. Which of the following cellular process has contributed most to the increase in our uterine size? What is the first option? Endometrial glandular hyperplasia. No, that's not the answer. B. Myometrial fibroblast proliferation. No, that's not the answer. C. Endometrial stromal hypertrophy. No, that's not the answer. D. Myometrial smooth muscle hypertrophy. Well, that's good. That's the answer. Then E. Vesicular endothelial hyperplasia. No. Why am I choosing D? Remember when we talked about the myometrium, we said it's a very big layer and it contributes largely to the what? To the cellular adaptation or to the changes in the uterus during pregnancy. Okay? Because it's very big, and during pregnancy, due to pressure, the cells there, they're going to become hypertrophic. The muscle cells are going to become big. Okay? They're going to become hypertrophic. So that one, it contributes very much to the what? To the changes in the uterus during what? During pregnancy. So that is the answer. The answer is D. Okay? So there is also some kind of proliferation that occurs where? That occurs in the endometrium. So in the endometrium, there's also some kind of cellular proliferation. So the things like the blood vessels, there's an increment in the number of blood vessels in the endometrium during pregnancy, and also even in the number of connective tissue, and there's also increase in the number of the epithelial cells. But those things, they contribute less as compared to the contribution that is made by what? By the myometrium. Okay, that's what you should remember. Very important. So now we can go to question 4. A 20-year-old woman breastfeeds her infant. On examination, her breasts are slightly increased in size. Milk can be expressed from both nipples. Which of the following process that occurred in her breast during pregnancy enables her to breastfeed the infant? So what happens is that during pregnancy, because of progesterone, so you know that during pregnancy there is high production of progesterone and estrogen. So progesterone and estrogen, they helps in keeping the endometrium layer intact in order to prevent abortion or the removal of the developing embryo from the endometrium. Okay, so progesterone has also another effect on the lobules of the breasts. So what will happen that the lobules of the breast, they will start proliferating in numbers. Okay, so they start proliferating in numbers due to the effect of progesterone. So progesterone is very important for lobular hyperplasia. Okay, these other ones are wrong. Stromal hypertrophy, no. Okay, ductal metaplasia, that one it is actually a pathological. So the answer here it is actually D, lobular hyperplasia. We can go to question 5. A 16-year-old boy sustained blunt trauma to his abdomen when he struck a bridge abutment at high speed while driving a motor vehicle. Peritoneal ravage shows a hemoperitoneum and laparotomy. A small portion of the left lobe of the injured liver is removed. 2 months later, a CT scan of the abdomen shows that the liver has nearly regained its size before the injury. Which of the following process best explain this CT scan finding? So we know that the liver, when it is damaged, what happens? The thing that's going to happen is that when the part that has been damaged or been cut is going to be replaced, right? That's what we said. That's what we said. So that is because of what? That's because of hyperplasia. So the liver divides, but when there's a need to divide. Okay, so the liver cells are able to divide when there's a need to divide. So during this incident, what will happen is that the hepatocytes will start dividing and replace the damaged portion of the liver. So that is process, it is hyperplasia. Okay. 6. A 71-year-old has a difficulty with urination, including hesitance and increased frequency for the past 5 years. A digital rectal examination revealed that his prostate gland is palpably enlarged to twice normal size. A transurethral resection of the prostate is performed, and the microscopic appearance of the prostate chips obtained is that of nodules of glands with intervening stroma. Which of the following pathologic process has most likely occurred in his prostate? Okay, so what has occurred in his prostate? So what has occurred here, it is actually dysplasia. Because the key thing that we should look at is actually this part, which is saying that intervening stroma. Okay, so obtained is that of nodules of glands with intervening stroma. Very, very important. Okay, so very important. So what is happening here is that these cells, they are dividing. Okay, and they are dividing when producing abnormal cells. That is dysplasia. So we are dividing and producing abnormal cells, but these abnormal cells, when they increase, they start invading the other tissues of the body, and that is what we call invasive carcinoma. That's called invasive carcinoma or invasive cancer. That's a cancer which is now spreading to the neighboring tissues. Okay, so dysplasia, like I said earlier, it can lead to cancer. Okay, and there are grades of dysplasia. We'll talk about that when we talk about cervical cancer. So when there's severe dysplasia, what will happen is that the tissues, okay, the dysplastic tissue will start invading other neighboring tissue, and that's what has been mentioned here. So the chips obtained is that of what? Of nodules of glands with intervening stroma. That's why we are saying the answer there is easy, dysplasia. And not apoptosis, not fat change, not hyperplasia, not hypertrophy, and not metaplasia. Okay? And what you should remember is that when dysplasia reaches a level where it is now invading other tissues, then that is called cancer. Specifically, the name changes and be called invasive cancer. We also have metastatic cancer. This is a type of cancer which spreads to all parts of the body. But invasive cancer, it only spreads to the tissues of the same organ, so to the neighboring tissues in the same organ. I want us to talk about cervical changes. Okay, so cervical changes that can result in cervical cancer, because cervical cancer, it's one of the most common cancers in females. So you can see here in this diagram that we have got the uterus. So this is the uterus, and then you can see there that is the cervical os. You can see that we have the uterus here, and this is the uterus, and then this is the cervix, okay, and then this is the vagina. So then at that point we have got what we call the cervical os. So what you should know is that this part here of the cervix, this is called endocervix. Okay, this part from there to there, this is called the endocervix, and then down here, this part of the cervix, this part, it is called the ectocervix. So the one that is exposed to the outside or to the vagina, that is ectocervix. Okay, so here at the junction here, it is called the transformation junction or the squamocolumnar junction. This is a junction between the endocervix and the ectocervix. That junction there. At that junction, we have got squamous as well as columnar cells. Here in the ectocervix, we have got the squamous cells. Okay, the simple squamous cells, and then here in the cervix we have got the simple columnar cells. That's what you should know. Okay, but what you should know is that here at the transformation zone, we have got a lot of immature squamous cells. And you know, those guys, those immature squamous cells, what they're susceptible to? Those guys are susceptible to HPV. So HPV, the human papilloma virus, this is a sexually transmitted virus that causes cervical cancer. So if you look at this diagram that we have here, the first diagram, it's simply showing us the normal tissue at that point, okay, in the cervix. This is how it looks. This is the normal tissue. And then here, you can see that there is some kind of dysplasia. Look at the cells, how they're looking. Some are small, some are big. Okay, look at this stage here. If you look there, you find that the cells there, they are actually small. Okay, and but you look at how cells are here. Actually, that's the shape. The shape is different from these cells. Okay, so now the shape is not that much different. Okay, the shape is not that much different, or rather, the way cells are looking here is not too much different from that, and that is what we call low grade squamous intraepithelial lesion. Okay, so what I'm talking about here is, guys, don't miss a point. HPV, it can damage what? The cells in the cervix. But HPV, it targets the immature squamous cells the most. And those cells, they are found mostly at the transformation zone. And that is where, most of the time, dysplasia starts. Okay? So HPV, when it affects those cells, what will happen? Those cells are going to become dysplastic. They are going to undergo dysplasia in order to accommodate what? That stress. So you can see the cells that we have here, or the tissues that we have here. And now, cervical cancer, or that dysplasia that causes cervical cancer, it has been divided into two types. Okay, we have got the low-grade dysplasia and the high-grade dysplasia. Okay, so this low-grade dysplasia, the full name is low-grade squamous intraepithelial lesion, LSIL. And then we also have what we call the high-grade squamous intraepithelial lesion. So this one, if you look at this one, the cells are more dysplastic, more disorganized. Look how they're looking. So this one is a severe one. So this is a severe dysplasia. This is the mild dysplasia. Okay, in the cervix. So these terms, they only apply to the cervical cancer or to the dysplasia in the cervix. Okay, very, very important to remember that. So the high-grade squamous intraepithelial lesion, it is also called the carcinoma in situ. This one, what does it mean? Carcinoma in situ. In situ, it's a Latin word which means in its place. So carcinoma in situ simply means carcinoma in its place. It's not spreading to other organs. It's not invasive. Okay, so if you look at this, it's not invasive. So this is the basement membrane there. Okay, and these are the cells. They're not spreading across the basement membrane. They're still here. Okay, so the high-grade squamous intraepithelial lesion is also called the carcinoma in situ. But if dysplasia continues due to HPV, what will happen is that cells now start invading the basement membrane. Look how it's looking there. Okay, that's neoplasia, and now that one, if you look at that, look how it's looking there. So these guys now, they've invaded now the basement membrane, and these cells now, they are cancerous. Okay, they are cancerous. So now this is what we call cervical cancer. So this is the carcinoma now, and now this is specifically invasive carcinoma. It's not metastatic carcinoma because it's not going to all parts of the body, but it's going to the tissues just within the same organ. Okay, so that is cervical cancer. That's what happens. So if you look at this image here, so this is the cervical os. Look, that's the cervical os, which means that's it's simply the connection between the uterus and the vagina. So you can see there cervical os, and look how it's looking here. Okay, so I've got the transformation zone, which is that region. That's where cervical cancer is going to start from, and then it's going to start invading other tissues around. So transformation zone, that's where you're going to find both columnar as well as squamous epithelial cells. Okay, here in the cervix, in the cervix there is what we call simple columnar cells, and then in the ectocervix we said there is squamous cells. But here at the junction here between the endocervix and the ectocervix, there is the combination of squamous cells as well as columnar cells. But I said the squamous cells that are found here, they are immature squamous cells. So these guys, they are more likely to be damaged by what? By HPV, human papilloma virus. And there's actually 100 types of HPV virus. So the one that causes cervical cancer, 60% of cases of cervical cancer, they are caused by what we call HPV 16. Okay, and then 10% somewhere there it's caused by HPV 18. All right, so I think this video I'm gonna end here. I'm going to make another video.